The patient is positioned supine with the knee flexed at 90 degrees. Arthroscopy surgery is performed using a 30-degree scope and a standard approach through the medial and lateral portals of the knee joint. The synovium between the anterior and posterior cruciate ligaments was cleared with a planer knife to expose the posterior compartment. Double posteromedial approach is established under direct lens. The synovium at the lower stop of the posterior cruciate ligament was cleared by a posteromedial approach, and the location of the fracture can be found. Clean the front of the fracture site using radiofrequency and planer knife. The posterior cruciate ligament was separated from the surrounding synovium tissue with a radiofrequency and freshened at about 2 of the posterior edge of the bone fragment. Place the tibial targeting device about 2 millimeters from the anterior edge of the bone fragment. A 2 centimeters incision was made on the medial aspect of the tibia, followed by the insertion of a 2.0 millimeters Kirschner wire. When the Kirschner wire penetrated the joint cavity, the length of the narrow bone tunnel was measured using an equivalent length wire. Subsequently, a 4.5 millimeters bone tunnel was drilled, with a length that was 1 to 1.5 centimeters shorter than the length of the narrow bone tunnel. The spinal needle was inserted through the bone tunnel into the joint cavity. The thread PDS suture was passed through the spinal needle. The spinal needle was removed and PDS suture was retained. The 3.0 millimeters anchor was inserted through the PDS suture in a reverse direction into the bone tunnel and fixed it at the junction of the broad and narrow bone tunnels. With the assistance of the suture grasper, the 2 differently colored tail lines of the anchor were threaded through the center of the posterior cruciate ligament. Then, the bone tunnels of 4.5 were established by locating the posterior inner and posterior outer edges of the bone fragment with tibial targeting device. The anchor sutures were introduced into the bone tunnels at the posterior edge of the bone fragment and led out of the joint cavity. After the bone block was restored, the anchor threads were passed through the fixing holes of the 2 outer row anchors respectively, and was firmly fixed under the entrance of the bone canal. The stability of the repaired fracture block was then confirmed.